again, if you're just joining, Dr. Elsayes could not be here today because he had another educational commitment. So it's my absolute honor to step into his shoes. I'm Victoria Chernak. I don't know. So it's my utmost honor and pleasure to introduce our current speaker, Dr. Tang. Anne Tang is an abdominal radiologist at Montreal at Centre Hospitalier. Okay, I can't pronounce it, Anne. He's just an incredible researcher, radiologist, expert in liver imaging. He's an associate professor of radiology at University of Montreal. He is a member of LI-RADS steering committee. He is the energetic and just an incredible leader of LI-RADS International Working Group. His drive and his vision and his eloquence and his knowledge are unparalleled. He is primarily responsible for the fact that LI-RADS is introduced and adapted in so many countries. He has worked tirelessly with leaders in various countries to translate LI-RADS in different languages. He has created an incredible group of experts which continue to disseminate LI-RADS across the globe. And it's just a very special, wonderful, kind human being and an incredible gentleman. And he also is a fantastic daddy to two very, very cute boys. With that, I'm going to pass the microphone to Dr. Tang. Dr. Tang.
Thank you very much, Victoria, for these kind words. I also wish to offer some praise for Khaled, Elsayes, who, with his exceptional leadership and vision for online radiology education, has been able to assemble a faculty for this liver imaging series very rapidly in times of COVID. So thank you, Khaled, for organizing this liver imaging online course and for having invited me. If there's one lesson that we've learned recently, it is that global problems require global solutions. And while liver cancer may not be an infectious disease, there are several concepts that are applicable worldwide, such as epidemiology, diagnostic imaging criteria, and assessment of treatment response. So in the next 40 minutes, I will discuss the globalization of LI-RADS, including a roadmap and discussion of barriers to overcome. I wish to disclose that I've received speaking honoraria from the following companies for topics that are unrelated to this lecture. And I also wish to acknowledge that I'm supported by a scholarship from the Fonds de la Recherche en Santé du Québec to protect time dedicated to research and international collaborations. As you know, LI-RADS is a big family, and I'm deeply indebted to the many members of the LI-RADS International Working Group who have provided feedback, insights, and contributed to LI-RADS translation and its global dissemination. This candid picture was taken during the 2018 RSNA in Chicago with some members of the LI-RADS International Working Group who have participated in a roundtable to discuss strategies for international dissemination of LI-RADS. In this lecture on the globalization of LI-RADS, I will discuss the vision and the execution. I will first list the objectives, present the current state of LI-RADS dissemination, show several maps to describe the game plan. I will then mention critical components of this game plan, including the imminent release or update of the lexicon, the justification for providing LI-RADS translations, and an action plan for unification of imaging systems. Now, notice that unification of systems is shown in a cloud. This is because this is the stuff dreams are made of, and it deserves a cloud. So let me share with you the dream over the next few minutes. My lecture will be divided into 4 sections corresponding to the following objectives. First, to describe regional variations in imaging of hepatocellular carcinoma, or HCC, to recognize the benefits of a standardized diagnostic system for HCC, to identify potential barriers to adoption of a universal system applicable to many geographical regions, and to propose an action plan for unification of diagnostic imaging systems. So let's start with variations in practices and recommendations for imaging of HCC between geographical regions. HCC is a worldwide challenge, as it is the fourth leading cause of cancer-related mortality. On this map, which illustrates the age-standardized incidence rates of HCC in 2018 for liver cancer, we can see that the incidence is highest in countries in red, located mainly in China, Korea, Southeast Asia, parts of West Africa, and Central America, followed by countries highlighted in orange, including the United States, and several countries in Europe, South Asia, and Africa. HCC is a growing problem with an increasing incidence in the United States, according to the SEER database. So in parallel to the increase in incidence rate, we can also observe an increase in the mortality curve. Also notice that these two curves have separated over the years. This is explained by the improvement in 5-year survival, which now approaches 20%. There are two key factors that explain this improvement in patient survival over time. Chief among these are the introduction of systematic surveillance programs in the 90s and advances in imaging techniques that have permitted detection or characterization of ever smaller tumors. There are multiple imaging-based surveillance and diagnostic systems. In Europe, the European Association for the Study of the Liver first established imaging criteria in its practice guidelines published in 2001, shortly after the seminal Barcelona conference dedicated to HCC. Within 2 decades, several societies have followed the example of EASL and incorporated imaging recommendations for surveillance and diagnosis of HCC in their practice guidelines. Several of these guidelines were subsequently updated to reflect advances in imaging techniques and radiology knowledge. Among these, LI-RADS has focused on imaging and has rapidly been expanded, undergoing 5 revisions since 2011. In 2018, a major milestone was achieved with the unification of LI-RADS and AASLD. In 2019, the Indian National Association for Study of the Liver, or INASL, has also adopted LI-RADS. Over the next few years, as we update LI-RADS, an objective will be to develop a universal system for imaging-based diagnosis of HCC. But to do so, we must first take into account regional differences. So I will discuss some of these differences over the next few slides. There are differences in target population. This table summarizes the relative risk estimates for risk factors of HCC. Notice that the relative risk is highest for hepatitis B virus carriers, HCV-infected women and men, and for populations exposed to aflatoxins, either alone or in combination with HBV. Notice that the relative risk is an order of magnitude lower for patients with alcoholic liver disease, NAFLD, and other features of the metabolic syndrome. The prevalence of these risk factors varies between geographic regions. So, for example, in Africa and East Asia, the largest attributable fraction is caused by Hep B in 60% of cases, whereas in the Western world, only 20% of cases can be attributed to HBV infection, while chronic Hep C constitutes the major risk factor. On the basis of the high relative risk, all major societies recommend surveillance of HBV and HCV-related cirrhosis. However, this summary table also shows many inconsistencies in imaging-based surveillance recommendations between societies for other factors that have a lower risk factor, lower relative risk. So the teaching point here is that there's a potential to harmonize the imaging-based surveillance recommendations based on relative risk, availability of imaging resources, and cost effectiveness. To sample the practices in different regions, members of the LI-RADS International Working Group have performed a preliminary international survey. And the manuscript that is resulting from this work has just been accepted for publication in abdominal radiology. The two aims were to perform an international survey and to guide the development of a unified system addressing regional differences, and to identify potential barriers to adoption of a standardized diagnostic system for HCC. The survey was sent to members of the LI-RADS International Working Group, whose members are key opinion leaders, liver imaging experts at different stages of their career, with a broad geographical representation in mind. The survey was also sent by the American College of Radiology to members of the Society of Abdominal Radiology and European Society of Radiology. The survey covered three themes: demographics of respondents and their level of expertise, imaging practices in their regions for HCC, and the use of diagnostic imaging systems in their respective regions. This pie chart illustrates the distribution of respondents. Now, please notice that the color scheme of this chart is adapted from the color scheme of the Olympic logo. So you can match, for the next few slides, the regions with the respective colors in the Olympic logo. Reflecting the multinational composition of respondents, 23% of respondents were from Asia, 6% from Australasia, 20% from Europe, 26% from North America, and 25% from South America. A majority of respondents, or 57%, were from academic practice and 34% in mixed private or academic practice. For imaging-based screening and surveillance of HCC, non-contrast ultrasound was the most widely used modality, used by 91% of respondents. But multi-phase CT and MRI were also commonly used for screening and surveillance. In particular, respondents from North America, shown in red, relied most heavily on CT and MRI as screening and surveillance imaging techniques. Multi-phase computed tomography was the most commonly used method for diagnosis, and this was followed by MRI with extracellular agents, or gadolinium dimebloomine, and by MRI with gadoxetate disodium. Image-guided biopsies arrived in 4th position for diagnosis of HCC. Biopsy was most commonly performed for lesions that are probably or definitely malignant, but do not meet imaging criteria for HCC. And biopsy was also used for lesions that are possibly or probably HCC. In LI-RADS terminology, this indicates that biopsy was mainly used for LRM and LR4 categories. The usage of major imaging features was variable, and the 3 most commonly used major imaging features were growth, capsule appearance on enhanced imaging, and non-rim arterial phase hyperenhancement. Overall, 94% of respondents used ancillary imaging features for assessment of liver lesions in at-risk patients. This was consistent across regions, indicating awareness to multiple imaging features and tissue contrast mechanisms that can help refine or modulate the probability of HCC. For assessment of treatment response, RECIST or mRECIST were most commonly used, followed by LI-RADS or no formal system. Interestingly, within each region, several systems coexist, some of which are specific to a country or region, whereas others for specific purpose, such as liver transplantation prioritization. Overall, in this sample, the 3 most commonly used diagnostic imaging systems for HCC were LI-RADS, used by 67% of our respondents, ASLD by 30%, and EASL-ERTC by 23%. A vast majority of respondents agreed that a standardized classification for the diagnosis of HCC was needed. 73% totally agreed, and 18% somewhat agreed. And they also agreed that an atlas and lexicon would help improve inter-reader agreement. So this is a summary of the key findings. Non-contrast enhanced ultrasound was most commonly used for surveillance worldwide. multi-phase CT and MRI for diagnosis. Biopsy is seldom used for lesions deemed definitely HCC or LI-RADS 5. LI-RADS, ASLD, and EASL systems were the most widely used among our survey respondents, and the majority of whom agreed that there was a need for standardized reporting, atlas, and lexicon. Now, admittedly, many respondents were members of the LI-RADS International Working Group, and therefore they were aware of its components and imaging criteria. While this may have introduced a selection bias favorable to LI-RADS, the membership nevertheless included broad representations from 5 continents. Marching forward, we'll have to address underrepresentation of Middle East and Africa, as well as underrepresentation of Asia relative to its demographic weight and the high prevalence of HCC. So we've seen that practices and recommendations for imaging of HCC vary between geographical regions, and any future attempt to develop a unified system should address these regional differences. Now that we've discussed sources of variations, let me discuss the benefits of a standardized and universal diagnostic system for HCC. The LI-RADS vision has been fairly consistent over the years, and the roadmap was very clear from the start. This excerpt is extracted from an editorial paper published in 2013 that announced the future components of LI-RADS. You can see that within that list, nearly all objectives have been or are about to be accomplished. The key concept back then that was announced in 2013 was standardization across imaging modalities, across components. In a follow-up paper published in 2018 entitled LI-RADS, A Glimpse into the Future, the paper announced future expansion, including several themes discussed in this liver imaging series over the past few weeks, such as pediatric liver lesions or quantitative liver imaging. This editorial paper also announced the need for a multidisciplinary effort to achieve unification of various diagnostic systems. So let me discuss the chronology of these two concepts by presenting a brief history of LI-RADS on this timeline. This timeline is adapted from an editorial written by Claude Sterling on his LI-RADS adventure. And I've updated some components based on earlier versions of LI-RADS on which I have collaborated since 2011 during my research sabbatical at UCSD. So the big picture is the following. You'll notice that in the first 2 years, from 2006 to 2008, we witnessed the creation of a precursor system integrating key elements developed at UCSD and Thomas Jefferson universities. So if there's any such thing as a LI-RADS mythology, I would call this the genesis of LI-RADS. The subsequent decade from 2008 to 2018 was focused on developing standardized algorithms, tables, and lexicons covering several imaging modalities, namely ultrasound, contrast-enhanced ultrasound, CT, and MRI, as well as additional contrast agents such as hepatobiliary agents. This is what I would call the standardization phase in the LI-RADS history. This provided a solid foundation that led to the unification of LI-RADS and ASLD in August 2018, which was a watershed moment. Now, building on the work of the last decade, we can anticipate that we will witness the unification phase of LI-RADS with other diagnostic systems over the next 10 years. To put this in perspective, let me show you the chronology of refinements and development of other systems. We must be patient because diagnostic systems evolve over a period of decades rather than years. This is because these systems must be created, refined, and validated before actual clinical use. This timeline shows that EASL, the precursor system, has seen 3 iterations over a period of 17 years. The Korean system has undergone 4 iterations over 15 years. ASLD, 3 iterations over 13 years, and LI-RADS, 5 iterations over 7 years. This is a rapid development cycle within 1 decade to focus solely on liver imaging. Now, on a light note, I would say that at 7 years old, LI-RADS is no longer considered in its infancy, but we could say that it's in its childhood, whereas other systems are in their teenage years. LI-RADS addressed the need to standardize HCC diagnostic criteria through an algorithm supported by an atlas, a lexicon, and a hyperlinked index. From a research standpoint, it is anticipated that a standardized system would facilitate international collaborations and advances in radiological knowledge. As of today, LI-RADS includes more than 250 members from more than 100 institutions and more than 30 countries. From a clinical perspective, LI-RADS standardization helps inform clinical management based on evidence. So a benefit of using a standardized system is that we can pull data from the literature and obtain estimates of percentage of malignancy or HCC for different observation categories. So for example, based on a meta-analysis by Christian van der Pol published in Gastroenterology, any practicing radiologist could extrapolate these statistics to his own practice. So for example, an observation categorized LI-RADS M has 93% probability of malignancy and 36% probability of HCC. An observation categorized LI-RADS 5 has 97% probability of malignancy and 94% probability of being an HCC. And so on for LI-RADS 4, 3, 2, and 1. Notice that an LR1 has 0% of HCC and 0% of malignancy, which is very reassuring to exclude malignancy. While LI-RADS is documented by a comprehensive manual, the essence of its diagnostic approach fits within 1 page, with a diagnostic algorithm on top and diagnostic table on the bottom. By now, the inter-reader agreement of LI-RADS categories has been well documented, as a large multi-center, multi-reader study has found substantial agreement on observation categories on MRI. This study has also found that intra-class correlation coefficient, or ICC, was not significantly affected by liver imaging expertise, prior familiarity with LI-RADS, or number of years of post-residency practice. LI-RADS has been and will continue to be refined in response to user feedback. And these animated screenshots show iterative modifications and refinements of LI-RADS over the years, starting with the 2011 version that was web-based, the 2013 and 2014 version that included an atlas, lexicon, and components on hepatobiliary agents, and the 2017 version that adopted a portrait orientation for print and PDF release. And while LI-RADS is not perfect, it's certainly perfectible, updated, and refined based on the feedback of its users. So far, I have focused on the past or the present. So let me now examine the future by discussing potential barriers to adoption of a unified system. Over the past 19 years, at least 15 scientific organizations and societies have published systems that include imaging-based criteria for diagnosis of HCC. So barriers to LI-RADS adoption include the multiplicity of the systems, guidelines, and languages, the lack of standardized terminology across these recommendations, and regional variations in resources, management, and diagnostic priority based either on sensitivity or specificity. I will discuss some of these barriers to adoption over the next few slides, starting with language. Perhaps because I'm a French Canadian Vietnamese of Chinese ancestry, living in the bilingual province of Quebec, and working in French, and dreaming in French, I'm exquisitely sensitive to language issues. English is by far the most common studied foreign language in the world, followed by French, Chinese dialects, Spanish, German, Italian, and Japanese. Although English is widely studied, the native languages dominate in terms of usage in daily life. In terms of demographic weight, nearly 2/3 of the Earth population speak one of these 12 languages as their native language. This is important to take into account because medicine is practiced in national languages and reports are often provided in the same national language. So let's keep this in mind as we will later on come back to the topic of translation of LI-RADS to national and supra-regional languages to promote dissemination and adoption of LI-RADS worldwide. In addition to language, until recently, there was no standardized terminology. So in this nice example provided by Claude Serlin and his team, we can see that to describe the imaging feature shown here, arterial phase hyperenhancement, there are at least 11 different terms that have been used in the literature. The challenge is that preferred terms are rooted in language, tradition, and preferences by individual radiologists. So adoption of a standardized terminology will take time, but this is about to change with the imminent release of the LI-RADS lexicon for terminology in liver imaging. It will require dissemination in scientific and educational lectures and publications over the next few years before widespread adoption by the broader radiology community. There's also a need to standardize the reporting of probability because language is inherently ambiguous. I've created this chart adapted from a survey conducted by Khorasani and colleagues, which illustrates the likelihood of disease for using common phrases used by radiologists on the left to express certainty and as understood by referring clinicians on the bottom, using a Likert scale from least certain to most certain. You can see that for many terms, there's a very wide range of interpretation by referring clinicians receiving a report mentioning compatible with HCC, for example. Now, let's contrast this with the LI-RADS categories, which have a much narrower and non-overlapping range of probabilities. So the objective of LI-RADS is to peel away the ambiguity associated with language and replace it with probability of HCC or probability of malignancy. There are also differences in priorities in terms of management and treatment selection. This is a remarkable graph from the large-scale international bridge study, which shows the proportion of patients undergoing different treatments for HCC. Now, first, notice the remarkable regional variations in treatment of HCC. And second, notice the relatively small proportion of patients actually undergoing liver transplantation. So despite the known efficacy of liver transplantation as a curative treatment, only about 2% of North American patients with HCC actually receive this procedure. By now, it's a common wisdom that Asian countries, which have a high pretest probability of HCC, rely more extensively on local regional treatments, such as TACE or radiofrequency ablation. Because of the lower risk of these procedures, their diagnostic thresholds tend to favor sensitivity over specificity. In contrast, Western countries that have a lower pretest probability of HCC and that prioritize eligibility for transplantation tend to favor specificity over sensitivity. And this was created intentionally to avoid false positive diagnoses of HCC, which can have dramatic consequences for potential organ recipients. Now, marching forward, perhaps it's time to revisit this concept because transplantation is performed in such a small minority of patients, even in Western countries. Let's now jump into the final section, which is the action plan for unification. Here is how I conceptualize approaches to unification of diagnostic imaging systems. In radiology, LI-RADS adoption has been driven by a clear vision set forth by the ACR, with solid and consistent leadership over a decade to fulfill the vision. This includes scientific work to accrue knowledge pertaining to LI-RADS. We also have educational material, such as this liver imaging series organized by Khaled Elsayes, to teach radiologists in scientific and educational meetings. Education has promoted the use of LI-RADS by radiologists in the field, including non-academic institutions. On this schematic, we can differentiate top-down approaches, which begin with leadership, and bottom-up approaches that rely on actual usage in radiology reports, which provide legitimacy to this system. The next challenge is diplomacy, to federate scientific societies of hepatologists and hepatobiliary and pancreatic surgeons. This includes societies that are listed in this diagram, but not limited to these societies for reasons of space. Marching forward, we will need to disseminate LI-RADS to hepatologists and surgeons because lack of awareness by clinicians has been perceived as a potential barrier for adoption of LI-RADS. In addition to the top-down and bottom-up approaches that I've discussed, we will also need to promote a transversal approach in which international colleagues from different societies and different clinical practice fields feel like stakeholders and equal partners in a multinational collaborative process. So here's a one-page summary of the action plan. Regarding unification or integration, we have achieved unification of LI-RADS and ASLD, as well as integration of LI-RADS into the Indian guidelines. Regarding the lexicon working group has defined the scope of use of different terms and iterated on refinements to the lexicon. We will submit an editorial perhaps later this year to promote the use of LI-RADS terminology in research and clinical care worldwide. In terms of translations, we've translated the LI-RADS core documents and made them available in widely spoken languages. And regarding barriers to adoption, we still need to identify barriers to LI-RADS adoption and discuss potential solutions for adoption of LI-RADS beyond North America and plan future amendments to address these potential barriers. Let me illustrate the key concepts mentioned in this action plan. The unification of systems will require multinational collaborations between several scientific societies across several continents. Here's an overview of the societies that we need to federate in the next few years. As of 2018, as mentioned earlier, the ASLD HCC guidance document adopted LI-RADS categories, color scheme, management recommendations, and unified LI-RADS 5 criteria. This constitutes a template for successful unification that should be replicated with other societies in the future. This is a major accomplishment whose credit goes to Claude Serlin, who promoted adoption of LI-RADS in the ASLD guidance document. And this figure reproduced from this reference illustrates the Serlin's algorithm, which tacitly adopts the LI-RADS ultrasound categories and explicitly adopts the LI-RADS CT MRI diagnostic categories and management recommendations. Another example of successful integration was the LI-RADS adoption in the joint consensus statement on imaging of HCC by the Indian National Association for Study of the Liver, INASL, and the Indian Radiological and Imaging Association, or IRIA. Their document adopted LI-RADS categories, technical requirements, ancillary features, and reporting templates. This is a screen capture from the INASL and IRIA consensus statement. which referred to LI-RADS technical recommendations found in the contrast enhanced ultrasound document. So some of the keys to successful unification include patience. Patience over a timescale of decades rather than years, collaborative and incremental work, mutual respect between stakeholders, ability to provide evidence through systematic reviews, meta-analyses, and prospective validation, and turnkey solution to provide a mature system whose legitimacy cannot be denied. An example of such turnkey solution is the lexicon. Members of the steering committee and lexicon working group have worked on a comprehensive lexicon that includes terms in liver imaging, definitions, context of usage, applicable modalities, comments, synonyms, context of use, and date of approval. This is a formal approach to approve and update the lexicon, which will be discussed in an upcoming editorial. Now, let me discuss the importance of translations. English is nowadays the modern Latin language, or default language for scientific and educational exchanges worldwide. However, at the reading station, medicine is usually practiced in national languages to communicate with referring physicians in the official language. So as someone working in Montreal, in the French-speaking province of Quebec, I must report my cases in French. So take, for example, this case, which I would describe as présence d'une masse de 4,5 cm au lobe caudé, série 11, image 20, avec hypervascularisation à la phase artérielle, lavage et capsule en phase veineuse portale et tardive à 3 minutes. Ouvrez la parenthèse, LI-RADS 5, fermez la parenthèse. Now, even those who do not understand a word of French understand my report because I use the LI-RADS 5 category at the end. Now, marching forward, LI-RADS translations will facilitate the use of standardized terminology in several languages other than English and facilitate pooling of data in a research context. In this example, using the two reporting templates provided by LI-RADS, notice how my example of structured text in a single continuous paragraph in French can be easily converted to a structured report with keywords and findings in English. Now, this is provided for two languages, English and French, but the translation of the LI-RADS lexicon will facilitate pooling and integration of data across several national and supra-regional languages worldwide. On this slide, I'm providing an example of the LI-RADS tumor in vein category, followed by the term in different languages or character sets. Okay. Notice the selection of national or supra-regional languages, which refer to languages spoken in more than one country. The work done for individual terms has been done for the LI-RADS lexicon 2 years ago and will be updated after the current revision of the LI-RADS lexicon is completed. This is a screenshot from a portion of the lexicon translated into 12 languages. The LI-RADS translations are available for free on the ACR website, and I wish to thank all those who have contributed to the translations. As of today, LI-RADS ultrasound core document has already been translated into 7 languages. The contrast enhanced ultrasound core document has been translated into 8 different languages. The CT and MRI core document is available in 11 languages plus 1 for English. So bottom line, LI-RADS is available in 12 languages spoken in these countries. And this map illustrates the potential penetration of LI-RADS in native languages as of today. This color-coded map shows countries using one of the 12 languages, including English, in which LI-RADS has been translated. These countries either use one of the 12 languages as their official or most spoken languages. It does not show countries where some languages are widely understood or spoken. So for example, Morocco or Tunisia in Northern Africa use French widely in their education system, in addition to Arabic. And to take another example, Scandinavian countries and many Arabic countries understand English perfectly in their higher education system. So the reach of LI-RADS is likely higher than what is shown on this map. I would like to highlight the contribution of the following members of the LI-RADS International Working Group that have made these translations possible. In particular, I'd like to highlight the leadership role of the guarantors of translation integrity who have coordinated this team effort in their respective languages. Their names are highlighted in yellow. It is thanks to their meticulous work that these translations have been made possible and have contributed to dissemination of LI-RADS in their countries, as well as other countries that share the same official language. If for any reason I have unintentionally forgotten to list your name, please inform me. In the final few slides, I would like to discuss the game plan to federate different diagnostic imaging systems. We believe that it is time to invite thought leaders to a virtual or in-person meeting, to include key opinion leaders with the ability to promote LI-RADS integration into their regional systems. We will plan a brainstorm session before the next LI-RADS 2021 update, and this will focus on constructive approaches to unify imaging systems worldwide. We must maintain a delicate balance of inclusiveness, representation, diplomacy between societies, and ability to federate. The deliverable that should follow would be a multi-society statement paper endorsing the use of LI-RADS in the respective systems. Some of the questions that will arise are the following. What are the barriers to adoption of LI-RADS in your region or country? How can we overcome these barriers? And which amendments should we implement in LI-RADS to address these barriers before the next LI-RADS 2021 update? As you've seen in my conceptual diagram, there are different ways to endorse LI-RADS, either top-down to journals or to national societies, but also by using bottom-up approaches to education and using clinical care, as well as transversal approaches such as multi-center, multi-reader research. This is my final slide with my take-home messages. In summary, globalization of LI-RADS will require endorsement by major societies, which include, but are not limited to the following: AASLD, OPTN, EASL, KLCSG from Korea, Japan Society of Hepatology, and APASL for the Asia-Pacific region. To be successful, international colleagues must feel like stakeholders and equal partners in a multinational collaborative process. Marching forward, we will adopt the LI-RADS lexicon in the liver imaging literature. We will make sure to translate LI-RADS into national and supra-regional languages and include hepatologists and hepatobiliary surgeons in LI-RADS education initiatives. And that concludes my presentation. Thank you very much for your attention, and I will welcome your questions.